Thank you very much for the invitation to speak at the meeting, and sorry I can't be there in person. I join you from London, albeit in the same time zone. In terms of talking about extending the limits of heart failure therapy today, I'm going to cover some advances in the field of chronic heart failure with reduced ejection fraction, and I'm going to confine myself to drug therapies for the heart failure syndrome itself and one of the comorbidities. In terms of extending heart failure therapy further, we have to remember we have a very high baseline to improve upon, and that is of course the class 1A treatments that we use for all patients with heart failure with reduced ejection fraction: ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, because of their wealth of evidence accrued over the last 25 years that these drugs convincingly lower all-cause mortality, cardiovascular mortality, hospitalizations for heart failure, and improve patient symptoms and quality of life. The first extension, of course, we had to this blockade of the renin-angiotensin-aldosterone system was with the neprilysin inhibitor combined to an angiotensin receptor blocker, sacubitril valsartan. Neprilysin, of course, breaks down the natriuretic peptide hormones, the good guys in heart failure that cause vasodilatation, natriuresis, and offset the augmentation of the renin-angiotensin-aldosterone system and sympathetic nervous systems that are in overdrive in heart failure. So the prototype angiotensin receptor blocker, neprilysin inhibitor, sacubitril valsartan, was of course trialled in the Paradigm HF trial in over 8,000 patients with heart failure with reduced ejection fraction, and it was compared to conventional therapy with enalapril, and of course showed a reduction in cardiovascular deaths, all-cause mortality and hospitalizations, roughly a 20% relative risk reduction on top of ACE inhibitor therapy. And of course that has now made it into most international guidelines in terms of a position of switching from an ACE inhibitor to sacubitril valsartan if patients remain symptomatic with heart failure with reduced ejection fraction. So where might that be extending in the future? Well, looking at two trials that have been published recently, we might see it being used in the future in patients who are naive to ACE inhibitors. The Transitions study looked at randomizing patients admitted to hospital with heart failure, some of them were ACE naive, to initiation of the sacubitril valsartan in hospital compared to initiation post-discharge. And you can see from the side effect profile of these two strategies, they seem to be similar, so there is no adverse effect in terms of hyperkalemia, hypotension from trying sacubitril valsartan in hospital. And in the Pioneer study conducted in the United States in just under 1,000 patients, patients were randomized in hospital to sacubitril valsartan use compared to enalapril. The primary endpoint was a reduction in N-terminal proBNP, and that happened with more efficacy with sacubitril valsartan. Again, with this strategy, adverse events of worsening renal function and hyperkalemia and hypotension were similar in the enalapril versus the ARNI group. And looking out to 8 weeks, patients who were randomized to sacubitril valsartan had a lower incidence of heart failure hospitalizations and cardiovascular deaths. So we may see ARNI going from a switch therapy to initiation in ACE-naive patients in the near future. I suppose the big extension is what to do after you're already established on an ACE or an ARNI, a beta blocker and an MRA. And undoubtedly the recent trials with the sodium glucose cotransport inhibitors have given us some hope here for additional therapies. These drugs were of course tried first of all in patients with type 2 diabetes who had cardiovascular disease or were at cardiovascular risk. And a consistent finding from these trials was that these drugs reduced heart failure hospitalizations. This then led, of course, to the large outcome trials in heart failure with reduced ejection fraction itself, starting with DAPA-HF with dapagliflozin. Dapagliflozin clearly reduced mortality, cardiovascular mortality, hospitalizations for heart failure on top of conventional therapy with ACE inhibitors, beta blockers, MRA, and indeed some patients who were already on an ARNI. This was followed up by a trial with empagliflozin, Emperor reduced, which reported last year. Again, empagliflozin reducing a combined endpoint of cardiovascular deaths and hospitalizations for heart failure. This time, no effect on cardiovascular deaths, but a significant reduction in heart failure hospitalizations. And most recently followed up by a trial in patients with worsening heart failure with sotagliflozin, which of course blocks SGLT1 and SGLT2 receptors. This trial drug started in hospital for patients with worsening heart failure and again reduced cardiovascular deaths, heart failure hospitalizations, and urgent visits for heart failure. So SGLT2 inhibition is undoubtedly going to have a major place in heart failure management for patients with a reduced ejection fraction in the future. But what about some newer targets? Well, there's been a lot of interest in manipulating the guanylate cyclase pathway in heart failure. The guanylate cyclase pathway ends with cyclic GMP, which is a vasodilator. And a potential way of manipulating that pathway is by augmenting soluble guanate cyclase. That's been looked at in heart failure, and there now has been a large outcome trial with the prototype soluble guanate cyclase inhibitor vericiguat in over 5,000 patients with heart failure with reduced ejection fraction on optimal medical therapy. The drug does seem to confer benefit in terms of a 10% reduction in cardiovascular hospitalizations, heart failure hospitalizations or cardiovascular deaths. The main effect is on reduction in hospitalizations. So that looks promising. In addition, we have an extension back to the future in heart failure, looking at inotropes, and this time a novel inotrope, omecamtiv mecarbil, a cardiac myosin activator that promotes the binding of actin and myosin into a very strongly bound force-generating state. It's been looked at in over 8,000 patients with heart failure recently in the GALACTIC-HF trial, and once again we see an 8% reduction in a composite endpoint of cardiovascular deaths or time to first heart failure event. Again, no reduction in cardiovascular deaths, but an improvement in the composite endpoint, maybe again showing some hope for the future for this inotrope in chronic heart failure. And lastly, a treatment for comorbidities. Morbidity is extremely important in an aging heart failure population. The mean number of comorbidities is 5. One of the best studied, of course, is iron deficiency, occurring in about 25 to 40% of all patients with heart failure. And this is iron deficiency with or without anemia. We know from smaller studies that intravenous iron improves effort capacity and quality of life in patients with heart failure. But now we have a larger outcome trial using intravenous ferric carboxymaltose in patients admitted to hospital with heart failure who have iron deficiency, and that's iron deficiency with or without anemia. The drug seems to again improve a composite endpoint of heart failure hospitalizations and cardiovascular death, with the majority of the effect here on reduction in hospitalizations for heart failure. So if we look back over the last 25 to 30 years with inhibition of the renin-angiotensin and aldosterone systems, and then more recently trials with devices, sacubitril valsartan, and we see major reductions in heart failure mortality for patients with reduced ejection fraction. And yet hopefully that number is going to be driven further and further down by the new extensions to the indication that I've shown you today. But we've not stopped. We've still got work to do. There's probably still a modifiable risk of between 12 and 20% in terms of excess mortality and cardiovascular hospitalizations to deal with. Thank you.